50% מה שאומר זה נכון. תודה רבה, זה כיף לא נורמלי להיות פה, יש פה די הרבה אנשים שאני מכיר. תודה לדורון שארגן את זה, אני לא ארגנתי את זה, זה דורון. הוא חשב על הדבר הזה כבר שנים, אנחנו מדברים על זה, ויש לו צוות מצוין שעובד על כל כך הרבה אספקטים, זה היה נהדר אתמול. לשמוע את כל הפרויקטים שקורים כאן. אז שוב, אני מכיר פה די הרבה אנשים, אבל אני רוצה to acknowledge בן אדם אחד, my best friend forever, דרור וסרמן, שנמצא איתנו. תודה רבה שהגעתם. ואני אמשיך לדבר באנגלית, בגלל שמרגרט סטובר, who is my mentor, is here also, and she speaks, she's yet to learn a lot of Hebrew, and also it's easier for me to give a talk in English now. I'm sorry, but אבל אפשר יהיה לקבל שאלות בעברית וכו'. אז תודה, ואיך אני מגיע לשקופיות שלי עכשיו? אולי מפה? לא? אני חשבתי שההרצאה הראשונה זה יהיה some baseline ideas rather than specific research findings. So PTSD is post-traumatic stress disorder, PTSS is post-traumatic stress symptoms. This is my disclosure slide. And what we're going to talk about in this talk is what's the definition of trauma, which is, it's a very general thing, but if you get that, you get a lot of the problems that we have with the definition of post-traumatic stress disorder and the differences between the DSM diagnostic criteria over the years. And post-traumatic stress disorder, of course, is something that happens after trauma sometimes. It's not the same as having been traumatized. And we'll talk a little bit about what happens in medical settings, and I will show you some data, some of which is not being published from our work. It's not groundbreaking, but it's data. So look at this description. We've broken up, and now I regret it. I said goodbye when I shouldn't have said it. I even cried, but I never meant it, and I don't know why, but I can't forget it. So it's about teenage crush. She broke up with a boyfriend, and is this trauma or not? And it might sound silly to you, but this very question lies at the basis of how we think about trauma and how it evolved over the years. You know where this is from? Anybody? No, there's no reason you'll know it. This is, have you heard of this one? Yeah. You have. Some of you did. Great. So this was about a breakup she had. And maybe she is less known, but this lady is much better known. Anybody wants to guess who this is? No one. And what if I told you that this is her name? I know. So for some psychiatrists will know who she is. This is the first psychoanalytic patient. This is the patient that psychoanalysis started with. And why am I bringing her up is because of one of her traumas. This is a trauma that is described by Freud and Breuer. And the story was that this patient, which by the way, they totally did not help her. After the psychoanalytic treatment, she had to be hospitalized for months. But, and then she got out and she was much better because they left her alone. But it's true, it's a story if I know. But during her meeting with but Freud criticized this case. He said that the therapy was not right, and that's how one of the most important psychoanalytic frameworks came to be. And the story was that during her meeting with her therapist, she recalled, and that's one of the many stories that she presented. She recalled an occasion when she was younger and had a glass of water, and then she saw her nanny's dog, who she didn't like that dog, drink from this glass. And because she saw the story goes, because she saw the dog drinking from that glass, this traumatized her. They call it a traumatic experience. Freud calls it that. And she wouldn't drink again. And she became dehydrated and so on. So this set up the stage for the psychoanalytic view of trauma. And this is, remember, this is even before World War I. But throughout the two world wars, this was the prevailing notion of what trauma means. And what it used to mean is that it's in the eye of the beholder. It could be something very minimal, like a dog drinking from a cup, and this could be trauma. And if you believe that, then you also believe that it's not about the event. It's about what you bring to the event, about, you know, maybe conflicts that you had with your mother that makes the glass look different. And this was a prevailing notion, and it's, now we think it's wrong, but I'll tell you why we think it's wrong. The reason we think it's wrong is not just because of data, but political. Because when this change was after the Vietnam War, where people went to war and people went to war that were normal, and then they came back and had, for example, PTSD, and they wouldn't agree to be called, like, you know, broken people because of something that happened in your childhood. They said, no, it's the war, it's the thing that we have experienced now that is the problem. And because, again, of a political force, the definition of trauma completely changed, and that's how we got DSM-3, which, as some of you know, is the Diagnostic and Statistical Manual of Mental Disorders. The third version is much different than the first and the second, and that's one of the main differences. And that's also an illustration of the difference in thinking before it was all about what happened to you in the past, and now it's all about the symptoms in the present. But that's not true either, because we know that people who are exposed to exactly the same traumatic event, some of them don't at all develop symptoms, some of them develop symptoms, and the symptoms are totally different. So it can't be really just about the event, and it can't be really just about what you bring to it. It's somehow in between or both, and that's why the definition of post-traumatic stress disorder has been in flux over the years. The DSM-3 said, you know, this is about the event has to be X in order to qualify as trauma, and over time we're refining and redefining what that X means, what is trauma and what is not trauma, and then what happens, what are the symptoms of the trauma. So again, it's always been, since DSM-3, the event itself, what can be a trauma and what isn't. We're still figuring it out. And then the second part of it is what are the symptoms that have been developed. And this tension is not just about information or data, it's also political. Okay, so, and why is it so important? This is just an example. They used to shoot people with PTSD in World War I. There were, how many? 300-some people who were just shot because of these symptoms, because they were considered to be too weak to withstand the war. That's how bad it was. Okay, so now we have the DSM-5, and I want to say that not many people who are trauma experts totally don't agree with the new definition, but I'm going to just tell you what it is and what are the differences. So the way the DSM-5, the new manual, defines trauma is that it's an actual or threatened death, serious injury, or sexual violence. And it should be either direct or witnessed directly, or learning about it, but only if it's a close person. Repeated exposure to details, but not through media. Why is that? Because there was one researcher who basically claimed that everybody in the United States is traumatized after the Challenger event, not even 9/11. That the Challenger exploded, everybody who saw it on TV became traumatized. So they say, no, this is not a trauma. But it's very torturous, and I urge you not to really follow this definition. It's too much. Again, you understand that it's all a flux, and we define and redefine. The point is, it's something serious that everybody would think is like a major event. It's not anything. And they threw out the immediate response of horror. It used to be that you also needed to have responded at the time in a specific way. No longer true. It has to be at least 1 month in duration, because these symptoms right after the trauma are so normal that we don't want to make that diagnosis at this time. And there are now 4 symptoms dimensions: avoidance of reminders, I don't want to think about it; intrusive recollections, I'm thinking about it even though I don't want to think about it. It comes to me when I don't want it to. And flashbacks. Hyperarousal is I am jittery. And now negative mood or cognitive effects has been added. They also added us a different set of criteria for children that are relevant to this audience, but I won't go through them. The point is, it's very hard to get these actual symptoms recognized by children, so we want to be more lenient. Now, many types of potential trauma lead to PTSD because there are many types of events that would meet those criteria, right? So what about military trauma? So with all due respect for the Department of Defense people here, this is rare. Actually, even in Israel. It's not the most common reason for trauma exposure. Disasters are really rare. Again, you get a lot of media exposure for hurricanes, whatever. How many people are actually exposed to it? Interpersonal violence is more common. And again, even in Israel, interpersonal violence is a more common reason to have traumatic events than the military. And medical trauma is actually very common if you think about it, because many of us would be exposed, even like soldiers who are no longer soldiers, they may also have an illness or they may have an injury, right? And for medical illness, it's the illness, but also it's treatment. And in fact, many times it is the treatment. And this is one thing that we did that was really interesting. It's a small sample. We reviewed patients in the pediatric emergency room in New York before 9/11, right? This was one of the few studies that were done before 9/11. And the most common trauma, which is to be expected in an emergency room, was medical problems. What we didn't realize is that the chronic medical problems were much more common reasons for trauma than injury or accident. Although most of the patients in that emergency room were treated for injury or accident, the chronic illness was the more common reason for actual symptoms, which was a little bit surprising. What was also interesting is that we did the same survey after 9/11, and there was no uptick. 9/11 did nothing to trauma levels in New York, and we waited for 2 years to write that paper because everybody was saying different things. So what do we know about prevalence? We have 6 to 30% depending on setting and age and so on. And we think it's probably as common as depression, PTSD is. And this is one study that we did with a very elaborate diagnostic process of a referred population where pediatricians said something's wrong with these kids, but we're not sure what. And you see in red the depressive symptom cluster. Here you see PTSD and adjustment disorder, which some of it is also what we would call post-traumatic stress symptoms. And you see that roughly it's the same level here it's really a diagnostic, meeting diagnostic criteria. Of course, most of the patients had nothing, which is what you would expect if you actually do a diagnostic assessment. So what can be traumatic is the illness. Of course, it's treatment, complications, and also what happens to others. So if you have a patient and they look at another patient near them who something bad happened to, that also could be traumatic, and we need to remember that. Who can be traumatized is the patient, the caretaker, siblings, friends, staff, and other patients. Okay, all of these people can be in that circle. Now there's the issue of post-traumatic stress symptoms. Most of you probably heard of it, and almost all of the research in medical trauma focuses on these symptoms. which means some, but not necessarily all of the symptoms of PTSD. The problem is, it's not a validated construct. Nobody knows what it is. Nobody knows how many symptoms need to be present for this to have a threshold. So it's a little murky, and we don't know. It's even, as I showed you, the diagnosis of PTSD, the disorder is in flux. This one is even worse, okay? Not very well defined. And is it the same as distress? We don't really know. We think not, we hope not, but it's not clear. And we also don't know if these symptoms are necessarily problematic, and I'll show you some intriguing data later. So I wanted to talk to you just because very few others are going to be doing this, about the parents, not the children. So can parents of medically ill children display symptoms of PTSD? And the answer is yes, of course they can have PTSD like anyone. Can they have actual post-traumatic stress disorder? Yes, but it is not very common. And you should remember, if you start to diagnose post-traumatic stress disorder, the full thing, in parents of children with medical illness, and you diagnose them, there's a lot of them, then you have a problem. The problem is how you define PTSD. It shouldn't be common, okay? But they do have these symptoms. And what do they do to the child is something that I was actually interested in, because we don't know exactly. I started by assuming it's all bad, but the data showed me otherwise. So this is a food allergy clinic. We had 250 parents of children with food allergy, and we administered a questionnaire, a post-traumatic stress questionnaire about the stress related to the child's illness, very specific. You don't know what this means, but you will know now when I tell you that everything to the right here is considered clinically significant symptoms of post-traumatic stress. So it's 32%, it's huge, right? And just to explain how bad it is, these are parents of children with food allergy, okay? The trauma being anaphylaxis, okay? We had the same questionnaire in a cardiology clinic to 1,000 or so patients who had a heart attack. And the level of symptoms, these were all Caucasian, of those who had a heart attack was 19%, with the parents are 32%. So the parents were more distressed than other adults who had their own heart attack. That's how bad this looked like. But is it really bad is a different question. It could be normative or normal. And this is one of the things that gave us a little pause, is that we looked at income as a function of the distress, and we saw exactly the opposite of what I thought would be. The higher the income, the more distress. And those were, some of them are wealthy people, and it's not just, it also works with education level, the opposite of what you would think in general about distress. And so why would that be? There's a really specific explanation in this situation that wealthy people are more likely to think that they can control their environment, and when they don't, they become more distressed. But that gave me a little bit of a pause. Maybe, I mean, unless you believe that having more money is really bad, this association was, well, maybe this distress is actually good in some ways. And then we did this study, which I'm very proud of. It's one of our cohorts. It's not large, but for the disease, it's the largest cohort that I think we ever had. It's 400 kids who had a liver transplant. And we had 386 caregivers answer questionnaires about trauma, and we looked at outcomes, and outcomes, they are very robust. It's rejection. And we also looked at adherence to medications. Do they take their medicines as prescribed? And what we found, and we looked at post-traumatic stress symptoms and also depression. So we have two strong outcomes 2 years after the questionnaire, so it's prospective. And we have assessment of post-traumatic stress symptoms in the parents, and depression in the parents, and adherence in the child. So we look at, again, I want to make sure it's clear, we look at symptoms in the parents as predictors of outcome in the child, okay? One is a behavioral outcome, it's adherence, which we looked at as a biomarker, and the other one is rejection of the organ. And what we found was there was no correlation between the stress in the parents and the adherence, and also no correlation between stress in the parents and rejection outcomes. The important thing about this cohort is that it's representative, which is, again, highly unusual in mental health studies. Is we usually do some convenience sampling. We get the patients we can get. This had a lot of safeguards there to make sure that those are representative of children who had a liver transplant in general. We found that depression was significantly associated with adherence and with, I think, some of the rejection outcomes. We'll see it. So there was no significant difference with the IES. For SESD was a trend. And rejection, remember, it's a very unusual outcome, so there are very few patients. So really it was depression. Both of those outcomes looked like it was depression and not necessarily post-traumatic stress. So in the next talk, I'll tell you why I think it's that. That does not mean we should only look at depression. I actually think it means we should look at stress because that's what happens before depression, but I'll leave it. There's a teaser at the end so that you will be on your toes for my next talk. But the parents can be quite resilient even if they are distressed, is I think what the data show us. And there are other studies that show it. I only showed ours because it's fun and because it's something that has not been published yet. I actually think parental distress can be protective. And especially with the food allergy, it could be that if the parent is distressed, they are doing more things to protect the child, okay? And I have learned in my clinical practice now, really a few hundred, if not more, parents that I looked at clinically, not just as a questionnaire, but in my work, that the parent I'm most concerned about, and the child I'm most concerned is the one who says, I have nothing, I'm fine. Okay, so to be a little distressed is probably good. And so whenever you see a study that says parents of children with food allergy are more distressed than the general population, maybe that's fine. Maybe it's great. Okay, don't believe that this is not our yardstick. We shouldn't compare them to the normal population on these measures. And then, and I think, and I saw that one of the talks are going to touch on this today is going to look at the adaptive aspects, is what we call post-traumatic growth, that we actually learn something from our traumas that is positive. I think in a medical setting, when you don't have resources, maybe you want to really flag those with depression. I also think you should flag those with PTSS, but for a different reason. Again, this is the next talk. And I do think for sure if they actually meet full criteria for the disorder, different story, for sure you need to treat them. Okay? So my summary here is PTSD is best used as a combination of exposure. Remember we talked about exposure to trauma and the experience of a constellation of symptoms that lead to dysfunction. Both of those need to happen. If you have the symptoms without the trauma, it's not PTSD. Even if you have all the symptoms, it's something else. It's not clear precisely which or how many symptoms are associated with dysfunction, and because of that, I think we need to look at dysfunction as a different construct, and that is something that Doron and I and his team were talking about. Examine dysfunction, look at quality of life as an outcome, and don't assume that there is dysfunction because there are those symptoms, okay? And I think that's just my thinking. I don't know that for sure. I haven't done those studies. But some distress is probably not just normal, but maybe even protective. So I wanted to say thanks to Doron. Am I on time? Because you said so much. Yeah? Okay. Great. So I'm good. Thank you to Doron again for putting it together. This is amazing. Itzik Yaniv from Schneider's is my mentor and the person under whose teaching, I started to be interested in this field. Gad Kotter is a friend of mine who some of you may know, who worked with me on some of these data. And Margie Stuber, who is here with us, my mentor. I remember I one day called her like cold turkey at UCLA, just because she was researching this, and since then we've worked together for years. Rachel Yehuda was also my mentor from Mount Sinai, and Ben and Shukru are the liver guys. There's a surgeon there, Georgia Mazariegos, and Rachel Annunciato, who's a psychologist who's working with me still. And of course, people who gave me money over the years. These are the consortia that I'm currently working with. And a teaser for the next talk. This is a question, think about it, we'll talk about it later. We know the following things, that depression is undoubtedly associated with poor medical outcomes in patients who had a myocardial infarction. We know it's true. Patients who had a heart attack and are depressed are doing worse than patients who had a heart attack and are not depressed. It's a fact. Okay? But when we did really large studies, thousands of patients, by the way, the largest study ever of cognitive behavioral therapy was done with cardiovascular patients, called Enriched. When we did these studies and looked at standard treatments for depression that we know work, okay, like sertraline or CBT, they do not work in patients with cardiovascular illness. Forget about that they don't improve their cardiovascular outcomes. That's true too. They don't even improve depression in these patients. And those are robust, randomized controlled trials that you can actually look at causation. So the question is, why is that? I will talk about it later. Thank you.
תודה רבה. יש למישהו שאלות? יש לנו 5 דקות לשאלות. שם למעלה? חנן? עברית.
You can ask in Hebrew and I will translate the question if that's easier for you.
בעצם אני רוצה לשאול אם הבנתי נכון את המחקר לגבי ההורים. בעצם האמירה היא שאם יש PTSD מבחינת הסף הקליני, אם זה עובר את הסף הקליני ויש הבחנה של PTSD, כן צריך לקחת את התגובות של ההורים לילדים ברצינות יותר מאשר PTSS בפני עצמו. זה
Okay, so the question is there a difference between PTSS and PTSD? The reason you didn't get it is because that was not the question I researched. The research was about post-traumatic stress symptoms. Now, one of the things you said, I don't believe is right, but again, I'll leave it for the next talk, is I don't think you should not pay attention to these symptoms. I hope that this was clear. I think those symptoms, when they are at the level of a symptom and not a disorder, are not yet associated with poor outcomes. Okay, that's exactly what we showed. Is at the level of symptoms, we didn't look at the disorder. We didn't even look at the disorder. I don't know if they have it. Some of them have disorder. At the level of the symptoms, we saw that it's not related to poor outcomes. Okay. What to do about it is the next session. I think in general, as a psychiatrist, not because of these data, that if you have a disorder, you need to treat it. So if they have post-traumatic stress disorder, you actually diagnose it, I think you have to treat it. Yes. So if somebody had an anaphylactic reaction 3 years ago, the child had an anaphylactic reaction 3 years ago, never had an anaphylaxis since. If they still have specific recollections of the event and are nervous about this, then I would call it post-traumatic. It's true that if they had it a month ago, then maybe it's too early. So it's a real question. It's not just in this. What about cancer? They have treatments all the time, and And I think that because of that, the medical trauma model is indeed a little problematic or questionable. Actually, I think in foodology it's cleaner than, for example, cancer, because there are many, many of those who don't have recurrent anaphylactic. In fact, most of them are that. But you can make the case, and again, I would agree with you, that post-traumatic symptoms are maybe not the best way to look at this because it's ongoing. I think when, again, in a clinical realm, or even some of the questionnaires, when somebody says, I have flashbacks, so in other words, how does it look like in foodologies? I feel like I'm having hives, but they don't. I feel like I'm having the allergic reaction, but they have not ingested anything. To me, it's more than distress. It's more the post-traumatic stress spectrum. But I agree with you that those definitions have not been thought through, and that's part of the problem with this monitor post-traumatic stress symptoms. Okay?
עוד שאלה אחת בלבד, בבקשה.
As you know, I'm working with cardiac patients, and I hope I'm not going to ruin your next session. Also, talking about what my former person talked about, you were talking about prevalence of PTSD symptoms in the medical settings, and we are very much interested in the content and in the color of the symptoms, and we are wondering if PTSD is prevalent but has a different content. And what we see in our cardiac samples is that not only they are contemplating about their past experiences, but mostly about their future cardiac events. And this is the procedure, this is the drama of PTSD in clinical settings.
I agree, but maybe it's no longer PTSD, which goes back to what he said. Maybe then this means. So what I used to, actually when I was writing grants, that's exactly what I said, is that it's very different and therefore we need other treatments and it's not the same thing because the issue is adjustment to a new reality. Whereas the classic post-traumatic disorder paradigm is you have something really bad, let's say a woman was raped. Something really bad happens to her, now she thinks all men are bad and you need to walk it back to where it was before and say it's the trauma, it's not the world that's changing. With those patients, the world is changing. So it is a really important context to put into it. And that's why there's some issues with this model for medical illness. It's not exactly fits together, I fully agree with you.
אוקיי, תודה רבה.